So I'm not going to do SFMA. I'm not going to have this young lady touch her toes or bend backwards or do anything of the sort. I can't run the risk of taking even these modest results and bringing her back to the second or third week in February where her life was turned upside down. Okay, so what do we do? Just had her sit. I had her sit on her hands, which is usually a way to give them a cue to maintain contact with the sit bones while we do a seated appraisal of hip internal and external rotation. And that's just a place to start because sitting is okay for her. So we sat and we did not learn much from the motion. So hip internal and external rotation did not provoke symptoms. But as soon as she sat down, on her hand, she's like, I feel something under my hand. I'm like, okay, that could absolutely be anything, relevant here. I said, is that normal? It's imperative I let her know that I care and I listen and I value. And that, of course, is a major clue in terms of if knowing full well that I can't do anything to remove a fragment from someplace where it doesn't belong, I also know that that is not the only anatomical or neuromuscular or even social construct that can lead to this type of pain. So looked at thoracic rotation and sitting and just to try to create some safety and movement on the most mild bit of variability. And I said, get up, move around. I said, is there any movement that you know that you can do? And if I somehow sprinkled pixie dust on you, would you know if it was better? And it was some kind of half kneeling side bending. That's our test. Because she picked it, she was comfortable doing it. I said, don't do anything to light yourself up. We went back to that seated position, and here's a very clinical message that will apply to many other people. One of the non-negotiable continuing education models that I think is crucial, for at least if the way that I communicate about clinical things, not the way I communicate with my words, and how we try to come to solutions and knock things off the board, is you must study. Again, you don't have to do anything, I take that back. I would strongly recommend some very guided mentoring, teaching, learning from Dr. Michael Shacklock. His brand is Neurodynamics. And remember, pain down the back of your leg, if we just call that sciatica, at one point I wrote down there was 12 completely different anatomical constructs that could help you guide. And of course, all of those different anatomical constructs are always going to be coded differently through what the patient believes, because this is what pain is and it's what it isn't. But sometimes that can work in your favor as well, meaning as long as the pain changes, you can use what may appear to be a pathoanatomical approach to affect the psychosocial relegation of what causes somebody to say the word pain, because it's just a word. Its word is just an analogy. An analogy is a representation of something. And if you don't know what's going on and fear and confusion is part of what you are perceiving, then pain could be a word to describe that. So think of, here we go. Hold on. All right. If I tried, and this is my sciatic nerve, and here's my foot, and it's only this long. And for some reason, up here on the left hip, where the shoelace goes through the shoe, it's held down. There's an interface issue, and it won't go. It won't go. It won't go. It won't go. So every time you try to lengthen this system, and again, that could be all the way up here from the disc level. It could be ascending, it can be descending. We're starting to get some illustration of what Michael Shacklock wants you to know and how he can help you. And I'm just translating it, and you will hear me say his name multiple times because he, just like others, always should deserve credit, and I will never be as good as him in describing it because it's his thing. He's so far out in front, and no matter how much I consider myself a student, I'll never know as much as him. It can be anywhere where now you may have multiple situations, but when this nerve doesn't want to get long because it's already long, then all of a sudden we can start to compartmentalize a neurodynamics thought process. Well, we get into what appears to be the slump test, and she can turn on her symptoms with no leg movements. So the sciatic nerve is completely slack. I'm like, oh, fuck, man, maybe this is something at the central mechanisms of the spine. And then look up. So we're trying to run ascending, descending, because it's really just the spinal cord north of here. Symptoms worsen significantly here. And again, that to me means, okay, we're slacking the spinal cord and symptoms get worse. Where she's sitting, I'm like, oh man, like, how are we gonna get there? How are we gonna get down into the hip and the length? Well, we tried anyway because there's no downside. And really what we tried to do is use the other leg. So when you do your slump test without the dorsiflexion on the opposite side, let me show you. So this is what I think is happening, and Michael Shacklock maybe see this. So you see how this won't go. Well, if I come over here and I give you all this slack, and I push not where the sciatic nerve is, but where it comes from the other side, and I give more room and more room and more room. So now all of this is up here. Now when she kicks or actually did that yoga kind of test, all of a sudden there's more room. So before you go right after the slump test, which is a very viable way in a non-painful, non-pathological situation, always try to mobilize the sciatic nerve before you try to stretch the hamstrings, and you'll find like magic. It's not magic. It's just because any message that it's all the same stuff is completely erroneous. You cannot mobilize the connective tissues of muscle, ligaments, tendons, collagen, elastin, titin if the nerve is the more primary component, because the nerve is still a form of connective tissue. The nerve goes by different rules, and that's important to recognize. Okay, so all of a sudden things are getting better, and we're not knocking anything out of the ballpark, but she's already starting to realize, okay, I didn't do anything to remove that disc fragment, but we're doing something. I started to explain. It's like, think of the shoelace. I'm slacking out the shoelace so you can pull the shoelace long on the other side, because everything on the non-painful side goes through the spinal cord. So there is a component there, and then it comes down the other side. You have a narrative that says there's only one nerve in the body. It's just all attached to the brain, attached to the spinal cord, and of course all the peripherals. So we're getting there, and we're getting there, and we're getting there. Then we went into this more treatment, and this is all active. And again, that was my approach, because I can't do anything that's going to be provocative. I can't risk this. And I'm letting her decide every movement. I'm like, do not touch her toes. At some point, she just randomly touched her toes anyway, and it seemed to reverse it. Okay, so this is still a threatening position. Treated glute minimus, glute medius, it's Connecticut, so I can use needles. Come at me, bro. And then also treated 5-1, 4-5, and 3-4, and significantly improved. The real issue now that I have to deal with is, and I say it, like, even if this is placebo, because the hitman came and showed up, but remember, that can't change if there really is something at the disc fragment that's impinging the nerve. So, the clinical message is neurodynamics. The clinical message, I'm not sure yet if this was truly a trigger point, even though glute medius and glute minimus can absolutely mimic 5-1 and 4-5, to not treat them. So what would I really want to do? I said, call your guy and tell him to do an ultrasound guided lidocaine injection. And even if it's just diagnostic, that's what the epidural should do. And then we went into it because they already knew by this time, like, this is all a bunch of trash. Like, do you think this was really the problem the whole time? I said, I can't say. I wasn't there. I don't know. I have no idea. Tincture of time was probably, the most evidence-based correlate to how this individual got better, because that's what evidence says: spontaneous recovery of back pain. That's completely irrespective of any pathoanatomical evidence that we had on MRI. More importantly, I can't go in there and move it. Putting a needle in the side of your hip, having you do a bunch of leg extensions on the side that doesn't even hurt, has no impact whatsoever on what that MRI says. Maybe an MRI that we can magically do right now would show us maybe that fragment isn't where it was before, but she still had pain and still had stiffness and still had this orthopedic malaise that something was not quite right. And walking up the stairs better, looking normal in these types of things. Again, my instructions were no exercises. There's no special exercises. There's no yoga. There's no Pilates. There's no lifting. Nothing. Just play with your new toy and make sure it stays this way. And then we dance, then we move. I would go after the lidocaine, simply more from a more firm, it's a bigger needle, so it's gonna have more of a mechanical effect. And I believe in lidocaine. I believe lidocaine works 100% of the time. And if these symptoms were more peripheral than what the MRI would suggest, then we got this. It's almost diagnostic. I don't really care if it lasts or not. That's not the point of what we're doing here. I don't know if they've gotten to that point or not. I don't think they're gonna do it because it's just too much noise now. Because yeah, I didn't do anything to significantly, sway their trust, but I don't know why would they trust them anymore. Now I understand why the epidural didn't work, because it should work. It's not the problem. The problem was not even though we did some red herrings that led me to be cautious, and maybe this is a central piece that can get lit up in any moment. It was more more peripheral. And that's where we went into, I couldn't rattle off 12, but in the past I have, of the different things that can cause significant, horrible leg pain, but we're not related to the disc, we're not related to the nerve root, we're not related to the stenosis, was not related to anything centrally. It was more as you scale down through the pelvis. So I think actually needling at the lateral hip probably didn't, traditionally hammer a trigger point, but if I needled out here and right here's the nerve and the tension is like that, ding, ding, and then it slacked it out. And then all of a sudden the nerve had more room because you weren't, it wasn't being held down. So then it could go, and then it could get short. It can get tensioned, it can get slacked. It can get tensioned, it can get slacked. It didn't have any of this. It didn't have any of that. That's what we used on the other leg. That's that neurodynamic piece that you do before, or if the slump test just isn't the right starting point. Again, you need to learn all this from Michael Shacklock. It's treating the nerve as if it's in a purely orthopedic structure, because when nerves get tight and tensioned under undue circumstances, they create a sensation, just like a muscle. And for most people, because of perception and, I have tight hamstrings, they don't feel terribly different until they're major pain. But then we don't think of tight nerve, we think of radiculopathy from 5-1 and 4-5, which is fair, it's good, clear it. Do every MRI you can do. Do every epidural. If it doesn't work, you don't just say whatever, because this was clear that there was other things going on here. And then, of course, if I'm going to play nice, I'm like, nah, this was all good to do. It was just incomplete. I got hot because of that message. That message really heated me up. There's a title of a book that one day I'm going to write, and I'm not going to say the title, but if you can corral, very, very difficult and in other cases caustic or toxic emotion and corral them, it's kind of like what the Red Lanterns are. The Red Lanterns are fueled by rage in the universe. Green Lanterns will, et cetera, et cetera. So I thought we were going to go WWE promo, but now we're talking about comic books. So we got that clinical message there of neurodynamics. You've got that clinical message, maybe called peripheral tension, that maybe would be another red herring for an SI issue. We've got to treat all these things. Not in this case. Don't be greedy. Don't be greedy. And there had to be a significant verbal and social treatment. I'm not really doing anything, but I have to let this person know that we're going to be safe and we're going to nail this, or I'm not going to waste time and be like, you should get this done now. I do not think that should be the case. I have no idea if they don't have spine surgery or other procedures in the future. Right now, there's a plan, and that's always what the goal is on day one. So that's, a number of things that at least I wanted to share, but I also think it's a window. Part of these videos is like, is it really about learning about neurodynamics and glute minimus, glute medius, trigger points? I'm not sure. I think that stuff is useful, but somehow just watching somebody else do what they do, it can trigger ideas for you. And how do you take a way of thinking? This is just what I think. And if you're at all interested, or you want to see Grumpy on my golf shirt, that's cool. I think the biggest thing that these videos are hopefully doing is giving you a voyeuristic view into just how somebody else thinks. And if you find value in that, I think that's a big win. I don't expect anybody to do what I do. I don't expect anybody to have every method and vice versa. I don't do everything that you do when you're doing this. And if any of this is not of clinical value to you because you're a coach, find the therapist that actually cares about people and cares about dominating results the same way you would sink 2 free throws with 0.8 seconds left to win a championship.